Well, good afternoon and welcome to Grand Rounds in Psychiatry in Behavioral Sciences. I'm Jürgen Onitzer, I chair the department, and I'm standing in today for our usual Grand Rounds host, Jet Thompson. So welcome on this beautiful sunny January Seattle day. Before I introduce our speaker today, I'm going to make a couple of comments about our Grand Rounds series in general. Uh, if you have any questions for our speaker today, best way to do that, put them in the Q&A feature in the Zoom application. I will keep track of that, and if we have some time towards the end of presentation, I will ask Dr. Bainline, our speaker, to comment on your questions. As you close out from the Zoom meeting, you'll be asked to do a brief evaluation if you have time to share with us any thoughts about this particular Grand Rounds presentation or our Grand Rounds series in general. We would appreciate that as well. For next week, we have a great presentation lined up, February 20th. If you have time to join us again, we will be hearing from Dr. Ken Minkoff, who's going to talk with us about a roadmap to the ideal behavioral health crisis system. So that's looking ahead to next week. But now let me move to our Grand Rounds presentation today. Today, it really is my great pleasure to introduce our speaker, Dr. Jim Bainline. Dr. Bainline is joining us from Oregon Health and Science University, just down the road here. And he's going to talk with us about cultural aspects of PTSD assessment and treatment. And I really look forward to this presentation, as I know many of you are. I'll say a few things about our speaker. Dr. Bainline trained in medicine at Case Western in Cleveland, Ohio, and then he came out west to do his psychiatry residency at OHSU. He also obtained a master's degree in anthropology at the University of Pennsylvania, where he was an RWJ clinical scholar. And for the past few decades, Dr. Bainline has been back at OHSU, where he has worked as a professor and as a faculty psychiatrist in a really interesting program, the International Psychiatry Program, where he has treated people from Southeast Asia, from Central America, from Bosnia, from Somalia, and a whole bunch of other areas. As he said to me a few minutes ago, over the past few decades, reflecting where the big conflicts, the big areas of stress were around the world. And his research focuses on cross-cultural psychiatry, particularly cultural and anthropological perspectives on post-traumatic stress disorder and how people adjust in the long run, to these kinds of stresses. He's worked with traumatized refugees. He's worked in the VA with veterans. And he's really interested in the interface of culture and medical ethics and some spiritual issues in psychiatry and also on medical education. Has a tremendous amount of experience in this area, and I really look forward to sharing that with us today. So with that, welcome, Dr. Bainline. Thank you for joining us for Grand Rounds. We really look forward to your presentation.
Yeah, thank you very much, Dr. Ernitzer. It's really a pleasure to be here and to be able to give rounds at University of Washington. And for 25 years, I also, besides my work in the intercultural program at OHSU, I was the Associate Director for Education for the Northwest Mental Illness Research Education and Clinical Center, the MIREC. So I worked very closely with our directors, Murray Raskind and Elaine Peskind in Seattle. And a number of my comments, as you'll notice as we go along, have relevance to VA. So I'll be talking about not only culture from the standpoint of ethnicity, but also military culture. And it has, many of the things I'm saying have universal significance. And so I'm going to be talking briefly about culture in medicine and psychiatry as an introduction, basic things that I think are important as a foundation. I'll be talking about cultural identity and how important that is in any type of psychiatric treatment, but it also is very relevant to recovery from trauma. I'll be talking a little bit then about sort of very basic definitions and comorbidities related to PTSD so that we're all on the same page. And then also talking specifically about culture in PTSD assessment and treatment, various aspects of treatment that have where culture is relevant. And also during the presentation, I'm going to talk about the role of us as clinicians and therapists across cultures, and then a very brief case at the end, which summarizes some of the things that I'll be discussing. I think this is a photo of taken in Cambodia in 1979 after the fall of the Khmer Rouge. And I've treated many Cambodian patients over the years, and not only for Cambodians, but I think for those of you who have treated people from across the world and across different cultures or in the VA with PTSD, I think that this photo is a metaphor in some ways for the psychological landscape that many survivors face. Just a few definitions. The culture has so many different definitions, but for our discussion today, I think it's helpful to keep in mind a number of things. Culture can be described as behavior patterns and a lifestyle shared by a group. It consists of knowledge, customs, habits, beliefs, and values. And it's changeable. It's learned and it's transmitted over generations. And through those multi-generational transmission, changes occur. So it's not at all fixed. Donald Brown, who is a anthropologist at UC Santa Barbara, he just died a little over a year ago. He studied universals in cultures. And much of the work in anthropology back into the 20th century focused on individual cultures and differences. But there are many universals that are relevant to all different cultures throughout the world. And some of these are particularly relevant to our work in psychiatry and medicine, such as beliefs about disease, beliefs related to sickness and dying, healing, emotions, empathy, fears, and also how communication occurs within cultures, using language or other nonverbal ways of expression. Cultural identity is, we're going to come back to this frequently during the presentation. Cultural identity is so important in working with people, particularly in trauma recovery. But identity has so many different aspects, and it's multi-determined. It's not fixed, and it can change through life stages and through various changes that people encounter in their lives. Cultural identity can include concepts such as ethnicity, race, national origin. For people who have migrated, it includes acculturation, which is a way that cultures change through contact with often the majority culture. And it is both social and it occurs at an individual level. Language, age, gender, sexual orientation, religious and spiritual beliefs and practices. I'll talk about that in a little bit more detail in a few minutes, and because that is relevant to PTSD and trauma recovery. And then also aspects of identity such as socioeconomic status, political orientation, geographic location, disabilities, one's work, one's profession. And then just a note about spirituality and religion. The spirituality is a larger umbrella term, just as culture is an umbrella term for all the things that I just mentioned. And spirituality often bridges religion and science. It includes insightful relationship between oneself and others. It informs personal values, meaningful purpose for life, and it's very much related to the amount of connectedness between oneself and the natural or the supernatural. And the concept of meaning is another thing that we're going to be talking about today, too, because that's such an important part of trauma recovery. Now, particular religious belief systems, the each of these things that I have listed here, the various world religions, there can be a whole semester of seminars on each of these. So these are just very general uh, uh, elements of each major religion that will be relevant for our discussion later. Religion across the world is allows human beings to deal with uh, things that are difficult to deal with, such as pain and suffering. And for some major world religions, atonement and forgiveness are part of the belief system. For Judaism, restoration of relationship with God through atonement is a central tenet. In Christianity, repentance and forgiveness and rebirth are important. In Buddhism, acceptance of suffering and reincarnation. Islam, death is divinely ordained. And that has an impact on survivor guilt because in my work with Muslim patients, many people say, well, it was God's will. I couldn't do anything about it, and Hinduism, suffering as a result of conflict and tension. An example of Christian concepts. I had a Vietnam veteran patient for a number of years who he did not have any hyperarousal symptoms anymore of PTSD, but he had difficulty in meaning, and he was a devout Christian, attended church regularly, and he felt that God, over a period of time, he felt that God had forgiven him for some things he had done in Vietnam as a member of the Special Forces, but he could not forgive himself. And over a period of time, this was just happened by accident. He befriended a Vietnamese restaurant owner in his community and got to know him on a very personal level. And that really promoted his own sense of repentance and forgiveness. And this went over a period of time, again, well after his PTSD hyperarousal had ended. Family microculture is a very important part of the concept of culture. It has universal importance. The family that the person both grew up in and also continues to live in informs secular beliefs and values, religious beliefs and values, beliefs about healthcare. And in our clinic, uh, the it's very common that medical decisions are made collectively, not certainly by just the individual, but by a number of members of the family. And many of our patients live in multi generational households. Now, that collective decision making can be very helpful for many of our patients who, of course, have dementia or chronic schizophrenia. Uh, but it does provide some tension for people with depression or trauma because there's that constant tension between individual identity and one's collective identity. But for many of our patients, particularly patients that I mentioned that have dementia, chronic schizophrenia, et cetera, having a uh, case, really an alternate case manager who's a family member at home makes our job as clinicians actually easier. I might say a word, by the way, about our clinic, how it's structured. We have 7 part-time psychiatrists who work at the clinic anywhere between a half a day and 4 days a week. And we have a large staff of case managers, counselors who are from the cultural groups whom we serve. So we work on a team with that case manager within our particular cultural group. And they also serve, besides being clinicians, they are also our interpreters for us, language wise. And so it's a huge benefit having a member of the treatment team as the interpreter who also intimately knows the patient and is not coming in and out and is a stranger to the patient. And that's a huge benefit, which I always really appreciate. Uh, Social and family roles are also uh, vitally important in identity within families and communities. These can be defined by gender or age. Uh, and as I mentioned, there can be conflicts between the one's autonomy independently and collective decision making within the family. And by the way, the conflict related to role reversals is not just related to people who migrate, who are refugees or immigrants, but also it is something that one sees with uh, military members who are returning from deployment after they've been away for sometimes a year or more. The family has changed, and the spouse or other members of the family have had to take on different roles, and people adjusting to those roles, the role changes, can be very challenging. Um, when I was working for the MIREC, we worked with the Oregon National Guard for a number of years in designing community education programs for faith communities throughout Oregon. And it was very, very rewarding working with the National Guard chaplains in designing these education programs where we would come in and talk about PTSD, trauma recovery, other comorbid conditions with PTSD to faith communities to give them a better understanding of the challenges that their family members and their social community members faced, uh, not only during deployment, but when they came home, and how that could be relevant to supporting not only them, but also their families while they were gone. So it was a very nice model of integrating sort of the science of PTSD with also community and social aspects. Uh, Along that line, talking about veterans, there was an interesting study done by Paula Schnurren, a group from the National Center a number of years ago when they looked at identity adjustment among Afghanistan and Iraq war veterans who had challenges with reintegration. And participants talked about uh, a number of interrelated areas of identity adjustment. And you can look at maybe the analogy to people who are migrating or immigrating to a new culture, uh, that there's some similarities here, feeling that one does not belong in civilian society, missing the military's culture and structured lifestyle, just as our patients in the cross-cultural clinic uh, are very much continue to be tied to their country and their family of origin who are still there. Feeling left behind compared to the civilian culture, their civilian counterparts due to military service, and also having difficulty finding meaning in the civilian world. And again, the concept of meaning being so important. So, what are some of the cultural factors in illness? Um, Culture affects how symptom patterns are exhibited across cultures. Uh, Cultural factors are important in the recognition of disorders by both cultural groups and traditional healers. Um, it also affects the culture affects the belief system a group holds in understanding illness and treatment. And even though universal life cycles such as birth and death occur universally, there are some cultural differences in how some of these challenges are addressed. It's interesting that over the years in the cross-cultural clinic, and this is backed up by the literature, I've noticed that both psychosis and dementia are universally observed across cultures as being significant uh, uh, problems for people. Uh, and that is because it really both of those conditions and the sub diagnoses under those conditions substantially affect uh, both personal and social functioning. And the really the symptoms also are very recognizable, and from the standpoint of psychosis, very obvious. For depression and PTSD, often the experience for people and the expression to the community and to us as clinicians tends to be more subtle. And PTSD hyperarousal symptoms, which I'll talk about in a minute, are obviously much more observable, but because they affect the anxiety and behavior. But depression often is much more subtle, and that and understanding does vary cross culturally. Uh, this I was involved in some community education on a couple of different visits to Cambodia a number of years ago, and we did. I worked with a non-governmental organization called the Documentation Center of Cambodia that has the largest repository in the world of documents and data related to the Khmer Rouge era, and the in the education programs with people in rural areas who were largely illiterate, even within Khmer language, we used a lot of nonverbal teaching aids. And this indicates a person, obviously, who is distressed, uh, who is imagining in the thought bubbles a number of the things that may be contributing to the distress, whether it's grief or loss, migration to the city, war, uh, a number of different things. And then on the right side are behaviors or uh, types of functioning that are affected by the distress. So, anger at the top, or isolation, or sadness in the middle, or substance abuse in the lower right hand corner. And these are types of healing approaches that can be helpful. And you can notice how many, talking about collectivist cultures, you can see how many of these are socially oriented. In the lower right hand corner, you can see, some of the things that are individual, such as meditation. But so much of the healing takes place in a social context, either with one other person or a family or a group, or with the help of a Buddhist monk. In the DSM, there's an outline for cultural formulation that has existed for about 30 years. And it provides a nice foundation working cross culturally to make sure we're not missing anything, either in our work with the individual or the family or our own responses to the patient. So the outline for cultural formulation in the DSM looks at the cultural identity of the individual, which I mentioned, the explanations of the individual's illness that may be a part of culture, And then cultural factors related to the person's psychosocial environment, and very importantly, the relationship between the person and his or her family and us as clinicians. Uh, Also, there's some other specific cultural formulation interviews that look at subcultures that one might encounter as a clinician. There's a cultural formulation interview for immigrants and refugees that looks at background, pre-migration life and difficulties that might be related to migration itself, and then ongoing relationships with the country of origin. What are some of the challenges that the person might face in their resettlement, and then future expectation. And as of late last year, there's also a cultural formulation interview for a military culture that's been now published by the APA, which interestingly looks at some similar uh, uh, categories such as pre-military difficulties, uh, difficulties that the person may have encountered during their service, and also what are some of the challenges after their service, and how they look at the future. Now, just briefly, talk about common PTSD symptoms. I've listed the most common ones that people encounter, and the first five are heavily physiologically experienced and observed, such as insomnia, nightmares, startle reactions, irritability. And the last few are often behavioral adaptations to the hyperarousal symptoms, such as avoidance, emotional detachment, social isolation. And those are often chronic and provide challenges for people even after the hyperarousal has been treated. I've listed anniversary reactions because they are so common, and I've seen this cross-culturally and with veterans, and they often disrupt the trajectory of improvement for people, sometimes on an annual basis and sometimes just once. But I listed it because I've seen it to be very important. Um, so many of my comments in the last part of the presentation are dealing with some of the uh, uh, behaviors such as avoidance, emotional detachment, and social isolation on a cultural level. Now, PTSD often intersects with depression and is comorbid with depression. And uh, depression commonly is, for many people with comorbid PTSD and depression, is more readily treated, and sometimes in a matter of a couple of months or 3 months. But PTSD often takes longer. But the overlapping symptoms that are commonly seen are insomnia, irritability, impaired concentration, anxiety, and withdrawal. And also, wanted to mention the intersection of PTSD and traumatic brain injury, which unfortunately for a number of decades was really ignored, and it has become much more observed, or clinicians, I think, are more aware of it in the last 10, 15 years because of some of the research done with people coming back from Iraq and Afghanistan, and some very nice work that's been done at the Seattle VA on TBI. Impaired concentration, impaired memory, irritability, depression, anxiety are symptoms that go across both diagnoses. And I have some patients in the Southeast Asian clinics who had uh, traumatic brain injuries, some significant ones. By history, again, one of the difficulties is we don't have any medical records for people dating back decades. But had significant TBI as children or adolescents, and that still really influences their the expression of their post-traumatic stress disorder. So we have to be aware of that in treatment. Uh, PTSD, comorbidity, and culture. So bringing some of these things together that I've discussed so far. PTSD has substantial cross-cultural validity, but there can be some variability in the prevalence of specific symptom clusters, particularly avoidance and somatic symptoms. And besides the PTSD hyperarousal, uh, we also see a number of somatic symptoms, both, of course, veterans and refugee populations, because there was a lot of physical injury for people. And as people age, I have some patients now in their 70s and 80s who, uh, where their arthritis pain from injuries that they sustained during trauma is just getting more and more difficult to manage. So it's important to be aware of somatic symptoms. And there's been some very nice literature in coming out of VA, which nicely explains the comorbidity of PTSD, depression, substance abuse, and chronic pain as interacting together and significantly affecting functioning, and which needs to be addressed in treatment. Um, Refugees with comorbid PTSD and depression also have been found to have increased prevalence of physical health problems, such as hypertension and diabetes. And taking medical comorbidity even further, uh, research with veterans and with refugees shows that hypertension, diabetes, and hyperlipidemia is significantly increased in traumatized populations. So ideally, comprehensive care for PTSD includes adequate screening for risk factors and signs of cardiovascular disease and diabetes. And optimal treatment for PTSD includes access to primary care along with cardiovascular and diabetes risk factor reduction. And we talk about this with patients a lot because there's a number of cultural factors that impact risk factors. And as you would imagine, diet is a huge uh, uh, part of that. And so we talk about not only the uh, symptoms of PTSD, but also follow closely uh, uh, people's hypertension and diabetes management in primary care. We, our patients, some of them have their primary care at OHSU in family medicine, but we also have patients who receive their primary care in the Providence system. And also in Portland, we have the Legacy system as another large medical system. And fortunately, we have access to those records through Care Everywhere, through Epic. Uh, One challenge that we have is a lot of the Vietnamese patients see Vietnamese speaking primary care providers in private practice. So we don't generally have access to those medical records. But fortunately, our Vietnamese case managers are very experienced and are able to get details about ongoing medical care through those private practices. So, what are some of the sequelae of trauma? Uh, Individual, some of which I've talked about, uh, anxiety, other anxiety disorders, depression, substance use, uh, family problems such as detachment and dissolution, neglect, domestic violence, and then social sequelae, destruction of social structures and systems, health, law, education, and religion. And Cambodia is unfortunately one of the 20th century examples of that. that where the health systems and the education systems and the legal systems were totally destroyed during the Khmer Rouge era, and it's taken generations to rebuild that. And that was also seen in obviously World War II, and unfortunately, it's going to be a sequela of other conflicts that are going on now in the world, such as Ukraine, Gaza, uh, Sudan, and other places around the world. What are some of the core assumptions that are altered by trauma for individuals? Well, a belief in personal invulnerability, and that's particularly important when a person is younger, where that might be more common than for somebody who's elderly. The perception of an understandable world, of laws or of predictability, trust in self and others. And the word trust is going to come up a lot over the last part of the presentation. Unpredictability of life and death, dealing with loss, and then moral complexities of right and wrong. And then there's for people that are refugees and immigrants and who have had traumatic experiences. There's also additional challenges such as uprooting, the loss of homeland, loss of work, family. As I mentioned, the changes in family and social role, language challenges, cultural values, and inability to access resources or other forms of discrimination. Universally, I think there's a number of things about PTSD treatment that one can consider, even though the specifics of treatment can vary. First of all, education. And the VA does a nice job with this, particularly in group settings through their symptom management groups, in introducing veterans to what PTSD is, what what's the etiology of many of their symptoms. That can in itself decrease anxiety and decrease stigma. Um, and then reduction of hyperarousal symptoms with medication or psychotherapy. So medication such as prazosin for nightmares, which also has a very significant impact on reducing insomnia and improving daily functioning when a person's no longer sleep deprived. And then also something like imagery rehearsal for management of nightmares. And psychotherapy can occur both on a number of different levels, individual, group, and family. And those are not mutually exclusive. They can occur all at the same time. And again, the VA is a very good model, particularly in the vet center system, for uh, not only groups, but also family groups that can be really helpful. In our clinic, in the intercultural program, we have ongoing groups in a number of the cultural groups. The Vietnamese case managers run several groups a week. We have a group for people with chronic psychosis. We have a group for uh, people that have had significant trauma. And also, there are groups for in the Bosnian groups, and also in the people for the people from Iran and Afghanistan, the Farsi speaking patients. In PTSD treatment, it's also important to reduce or eliminate other stresses that the person might have, and deal with social and vocational challenges as the person improves. Um, the symptomatic relief of other conditions involves, of course, attention to depression and TBI, which I mentioned a few minutes ago, and also substance abuse. Fortunately, in our clinic, the prevalence of substance abuse is quite low because of the cultural prohibitions for alcohol abuse or other drug abuse. Um, and also, part of that is related to the majority religious orientations of many of our patients. So, um, the great majority of my Somali patients are Muslim, and any kind of substance use is really proscribed in that group. That's not to say that there aren't people who have substance abuse problems. We have to be we have to screen carefully for that, but it is definitely less than, for instance, in many VA clinical situations, and it does reduce some of the challenges of treatment overall. For instance, most of our patients with chronic schizophrenia in the intercultural program do not have comorbid substance abuse, and that makes management much easier. Um, so there are certainly important barriers to treatment. Um, Avoidance, one's pride and self-reliance, loss of control or autonomy. Um, in many cultures, treatment is for those who are weak or, quote, crazy, unquote. And I included the word crazy there with quotation marks because I've heard that word in whatever language, specific language it is, countless times over the years, where people were reluctant to come to our clinic because even though they did not have psychosis or delirium, or uh, they would be labeled as crazy because they were going to a mental health clinic. Um, and there's also, and again, this is universal, there is a fear that the provider, the clinician will not understand or believe the trauma. And it often takes time for the actual trauma to be revealed as trust improves. And that is particularly the case, as you would expect with sexual trauma. And societal rejection is a big issue. There's often underreporting of symptoms, distress, or one's functional impairment, because it's embarrassing for people to have a reduction in their duties related to their social or family role. And uh, as I mentioned, there's a large focus on somatic symptoms, downplaying of emotional suffering, and sometimes related to culture, uh, the affect can be quite variable. Obviously, the individual person, there can be differences individually within cultures, but there's no question that within cultures, uh, specific cultures, there can be differences in what's sort of expected in showing emotions. And for example, even people that I've treated for decades in the Cambodian and Vietnamese clinic, uh, they're if a person is crying, they they try to hide it, and even though they know me really well, and I might just see a tear at the corner of their eye. Um, Whereas with I've noticed with the majority of people from Somalia, Bosnia, Iran that I've treated over the years, I know much more how they are feeling because they tend to actually express it in a much more external way. Again, I want to avoid obviously stereotyping because I feel that that's not stereotyping, but there are definitely differences, but also obviously differences individually within particular cultures. Um, and then language and access to a trained interpreter is vital in being able to understanding people's needs. Uh, Trust, security, grief and mourning, acceptance, meaning, re-examining one's social role, and then rebuilding social connectedness are universal healing challenges after trauma. PTSD involves most of the time uh, some type of major loss, whether it's uh, emotional, material, uh, death, or physical, some kind of loss of physical functioning. So there is often chronic grief and a process of mourning that occurs. Um, I'm seeing a Cambodian man right now who's just referred to our clinic last fall, and he's middle aged, uh, but he lost most of his family, his siblings, and his parents when he was a preschooler, and he has never had treatment, and we're building. It's taken several months just to focus on the first three issues there: the trust, security, and then uh, going through a mourning process. Um, he doesn't trust doctors very much. He doesn't trust the medical system. So he's very reluctant to consider. I was suggesting, since he's still having some nightmares that are affecting his sleep, I suggested starting prazosin, but he's very, very reluctant to do that. And instead, we're focusing on other issues that will be actually long term. Uh, Religion and spirituality across cultures. Religion and spiritual issues serve as explanation of how the universe began, how life is maintained, what happens when life ceases to exist. It affects meaning and the rationale for suffering, and the rationale for the existence of good and evil. Think these questions that we don't have an answer to, but patients and clinicians struggle with. And it's important to see that healing can occur through symbols and beliefs and values and cultural uh, rituals. Uh, a couple of books that have had a big impact on the view of treating trauma survivors throughout my career. Uh, uh, One of them is John Bowlby's work, Attachment, Separation, and Loss, uh, which is just a beautiful way, I think, of being able to look at the challenges that people have with attachment, particularly after trauma. And then Viktor Frankl's Man's Search for Meaning, which, uh, uh, even though it is relevant for his experiences during the Holocaust, is very relevant universally across cultures as far as people, what challenges they have. So the understanding of how the mind and body function, various cultural healing traditions, religious systems, and social structures is important. Uh, the integration of past, present, and anticipated future experiences is a human characteristic intrinsic to all theories of human development and learning. And looking at people's various developmental stages uh, and where they're at the present time, regardless of age, can be very helpful. Um, the Australian psychiatrist Derek Silo looks at adaptation and development after trauma from various pillars that hold up society. And I think that these are also relevant for individual and family improvement after trauma. It's not just larger social uh, uh, entities. CBT has been found to be a significantly effective treatment for PTSD and panic attacks among Vietnamese refugees and Cambodian refugees, but there's not a lot of literature in many other groups. And some of the literature is particularly related to narrative exposure therapy, uh, is based on studies of really that are not particularly good methodological quality. So one has to be careful in adapting Western forms of psychotherapy to across cultures, but it can be done, particularly various forms of CBT. Um, And it's helpful to use a patient's life story to assess their strengths, including family and social support networks, connecting the dots of different life experiences to make uh, coherence and make meaning in the present. We use that approach a lot. In a group for World War II in Korea, the war POWs that I was a co-therapist in for 30 years during my VA career. And as people aged and faced challenges in their families, either through uh, uh, the developing dementia of a spouse or the drug abuse of a grandchild that they had a lot of contact with, these types of experiences increased, uh, at least for a short time, their PTSD symptoms. So it was important to look at how the social and relationship issues that people had and the challenges affected their treatment. I'm not going to go into detail about dreams and culture, but just to say that they're universal and uh, and they have different meaning across cultures. But attention to nightmare content and the course of nightmare improvement can be really helpful in gauging overall improvement for people. And as I mentioned earlier, uh, really being aware of how to treat nightmares, both with medication and with cognitive interventions. So, clinical suggestions. Um, I've talked about this. This is a summary of some things I've discussed: awareness of individual strengths, determining level of acculturation, normalize difficulties in transition, being aware of the impact of the fragility of relationships and the importance of how values and cultural issues evolve over time. Don't be intimidated by a lack of knowledge of specific cultures, but concentrate on some of the universals I've talked about. And also, us being, as clinicians, being aware of our own backgrounds, our own experiences with illness, our professional education, and how that affects how we view various forms of treatment. And don't discount intuition and experience in treatment. And of course, general ethical principles, causing no harm, the primacy of reducing suffering and promoting health, and respecting autonomy and dependence for patients and their own creativity and their own uniqueness, but in the context of the family and social uh, milieu in which they live. We're going to, have sadness and anger, vulnerability, um, intolerance, maybe of other patients who have not suffered as much as many of the patients that we encounter. And I've noticed this among for myself, over the years, being more intolerant or avoiding violent images or violent films, um, and constantly dealing with the balance, somehow in the middle between over involvement or indifference, and that's a constant challenge for clinicians. Just literally a couple minutes, so we have time for questions. Uh, this is a uh, young Guatemalan woman that I treated in our clinic. And she came into the clinic with intense PTSD hyperarousal symptoms. And she was from a indigenous Mayan cultural group. She had nightmares and intrusive thoughts of the murders of her parents and grandparents when she was 8 years old. So she was just school age. And she was in her, this was 20 years later. She had been dealing, particularly since she arrived in the United States, significant PTSD hyperarousal. And she married a man, very supportive, wonderful guy who came to every appointment. And I saw them together. And she had a 3-year-old son at the beginning of treatment, and a second child was born during the time that she was in treatment, which was about 3 years. The symptoms resolved over after 2 years, and she wanted to continue for another year. The reason I'm mentioning this case is that we had to address, of course, the hyperarousal symptoms and that helped her to be able to concentrate better. The medication really helped her to sleep better and it reduced her nightmares, and she wasn't as sleep deprived. And what her husband noticed as she got better, and the patient herself also noticed this, secondarily because of what he was explaining to her, is that as she got better, she her children, including the infant son, their nonverbal response to their mother was more vibrant. It was more real. And as that improved, she herself widened out emotionally. And their relationship as a husband and wife also improved. And I think it really illustrates, a two-way street of improvement in PTSD and social and family functioning. The other thing that is important for this presentation is that I often ask people when they get better, what do you think has contributed to your improvement? And I've heard this across cultures with Somali patients, Cambodian patients, this Guatemalan woman. She said, well, three things. And people mention this in no particular order, but they say, well, the medication, my family, and God. So some combination of those various elements. I've heard from many patients across various cultures. Um, so we have, looks like about 5 minutes for comments or discussion.
Hey, well, Dr. Bainline, thank you so much for a wonderful presentation and also for sharing with us some of the pearls and the tools for how we can attend to cultural and other individual and family variations as we work with patients from backgrounds and life experiences that are just different from ours. If we have, I have one question here, I'll start with that, but if there are others, please type them into the Q&A function. So this one is, I'll read it for you. Can you talk about applying the CFI to PTSD after a person experiences psychosis? My understanding is that PTSD can be missed in patients who present with psychotic disorders.
Uh, Really good question. It's a complex question. It's hard to answer probably in just a couple minutes. But you're exactly right that PTSD can be missed in people with psychotic disorders. And of course, that can occur in community settings where a person has not had any war trauma. It can be related from child abuse or other types of conditions. And the you know it's it, it's comorbid, of course, and the PTSD symptoms. I think first of all, I think it's important to uh, screen for all types of psychiatric conditions when a person presents with psychosis, because as part of the history, you may have been able to determine that they've had significant trauma, and they may be having nightmares as part of their inability to sleep that are related specifically to the traumatic experiences. And it's interesting that over time, I've seen a number of people in our clinic with quasi psychotic symptoms, but are related really to the trauma because they don't have other types of behavioral or social functioning problems that one might see in someone with, say, schizophrenia or bipolar disorder. They're still functioning quite well, but they're not, and but their symptoms, which seem to be psychotic, are really related to trauma.
Yep.
So,
Very good. Yeah. So with 1 minute to go, I will finish with a question, and that is not only a wonderfully experienced clinician, but you also spend a lot of time being an educator. And we have a bunch of educators here in our department. And maybe could you share with us a few tips for how to best bring some of the wisdom, some of the knowledge that you shared with us today to trainees, either earlier in their career, medical student level, or maybe residents, fellows, people who are just getting started? Any thoughts, any tips you could share with us? What's the
Sure,
best way to do that?
sure. I think one is to reflect on one's own experiences when you're encountering patients for the first time, and put yourself in their position, coming to you as a clinician, and knowing that they're probably going to be anxious, regardless of what the reason for the referral is. Um, and I think the other thing is to not get get caught. I alluded to this during the presentation, not to get caught up in the specifics of the culture if
Mhm.
you're not familiar with it, and because you can always learn that from people that you're working with who are from that culture, and not don't hesitate to ask questions of the case manager or other people that you're working with, because you can learn that. But it's important to pay attention to the some of the universals that I talked about, and to you know I don't mean this to be a cliche, but um, to be yourself, and because patients will be able, they're going to give you a lot of slack if you don't know the tenets of Islam, or the history about their country. Because if you are truly interested, and you
Mhm.
and you are interested in their life history while you're taking a good history and a good psychiatric interview and medical interview, they will be understanding of that. And the affect that you convey to also is really important. And how you come across to the person. Of course, you can't control that, and it's hard to control that sometimes when you have a bad day, but to be aware of it.
Wonderful. Well, thank you so much. We're at the hour here. We are taping this. So for those of you who would like to see it again, it'll be on our website within a couple days. And for now, just a huge thank you to Dr. Benline for this wonderful presentation and for spending time with us today.
Yeah. Well,
Take care.
thanks. It was great to be able to do this. Thanks. Thank you very much.
Thank you. Thank you.
Yeah.